Hello and welcome to Public Health Live for the third Thursday breakfast broadcast. I'm Benita Zahn and I'll be your moderator today. Before we get started, I'd like to ask that you please fill out your online evaluation at the end of the webcast. Continuing education credits are available after you take our short post-test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best serve your needs. As for today's program, we'll be taking your questions throughout the show by phone. The toll-free number is 800-452-0662, or you may send your written questions by email. Please email us at any time throughout the hour at phlive.ny@gmail.com. Today's program is Collecting the Data, First Steps in Achieving Health Equity. Our guests are Dr. David Zingmund, an Associate Professor in Residence at the David Geffen School of Medicine at UCLA, and Dr. Marcia J. Wilson, the Associate Director, Department of Health Policy, School of Public Health and Health Services at George Washington University, and Dennis Whalen, President of the Healthcare Association of New York State. Thank you all so very much for being with us. Now, according to the Center for Disease Control's Office of Minority Health and Health Equity, minority health determines the health of the nation. Why is this so? The United States has become increasingly diverse in the last century. The 2010 U.S. Census documented approximately 36% of the population belongs to a racial or ethnic minority group. This proportion is expected to grow to over 50% within the next 30 years. And in this context, while health indicators such as life expectancy and infant mortality have improved for most Americans, some minorities continue to experience a disproportionate burden of preventable disease, death, and disability compared with non-minorities. Therefore, it's clear that as this segment of the population grows, the future health of the nation will be determined to a large extent by how effectively our society works with communities to eliminate health disparities among those populations. Today's webcast will discuss the important and leading role that our state's hospital systems play in meeting this challenge and, in particular, the vital importance of creating a system for collecting standardized racial, ethnic, and language patient data as a critical first step in achieving our goal of health equity. Specifically, our panel of experts will address the rationale for data collection, including the challenges we face related to the design, implementation, and maintenance of a standardized data collection effort. In addition, they'll explain why hospitals, emergency rooms, diagnostic and outpatient surgical centers are logical places for data collection and provide a roadmap for how to begin making the changes necessary to succeed. To begin our program, we're going to hear from Dr. Nirav Shah, Commissioner of the New York State Department of Health. He'll elaborate on why the issue of health disparities is so important.
You know, despite all the advances we've made in the healthcare delivery system, health disparities are highly prevalent, and there's a lot of evidence to support that notion. If you look across almost every measure of well-being in the United States, there are large health disparities, and they're not going away. Health disparities have been defined by the Institute of Medicine as racial or ethnic differences in the quality of healthcare that aren't due to access-related factors or clinical needs, preferences, or the appropriateness of an intervention. Research shows that racial and ethnic minorities tend to receive lower quality of healthcare even after controlling for factors such as insurance status and income. And this evidence is consistent across a range of illness and healthcare services. The issue of health disparities is something that requires all of our attention. While we've seen significant improvements in health and longevity over the last century in the United States, these benefits have not been uniformly realized by all Americans. Life expectancy has actually improved by more than 4 years for Americans over the last 30 years, since 1980. But for Black Americans, they still live 4 to 6 years fewer than whites. Factors that contribute to those disparities include income, education, environment and economic conditions, specific health behaviors, access to health care, and the quality of that health care. You know, on the flip side, certain vulnerable populations actually get the wrong kind of care more often in terms of amputation, in terms of getting their teeth pulled out. rather than getting a root canal. These are things that we want to avoid. And ultimately, these differences in health care between minorities and non-minorities are associated with higher mortality. If you look at age-adjusted death rates per 100,000 people for the 4 leading causes of death in the United States, they are always much higher among blacks and African Americans compared to whites. Heart disease. On average, 247 blacks die of heart disease versus 187 whites. For stroke, 60 blacks versus 40 whites. For cancer, 215 blacks versus 177 whites die. These kinds of statistics are borne out everywhere we look, that ultimately this bad care or inappropriate care or overutilization of the wrong kinds of services consistently leads to poor outcomes for our underserved minorities. So what do we do about this problem? We really need a broad approach that brings in all the players. And what we really need to start with is high quality, reliable data to put boundaries around the problem. So we need data on the race, the ethnicity, and the primary language of patients at almost every point of care. And once we improve the data collection, we can allow healthcare professionals to enhance their ability to interact with patients and provide real-time solutions. As we evaluate their work over time, we will finally start to address the challenges that we really face in every sector of healthcare today. I think we should start with our hospitals for 3 reasons. First, there are many national organizations such as the American Hospital Association, the Association of American Medical Colleges, the American College of Healthcare Executives, and many others who have already started work in this area with their national call to action to eliminate healthcare disparities. Second, New Yorkers recognize hospitals as leaders of healthcare in their communities. And finally, hospitals have an established history of experience with quality improvement and quality assessment. They, better than anyone else, have been doing this kind of work more than the outpatient setting, more than nursing homes, and so are equipped to help advance the goals that we all have. We're also looking to get support from state and federal funds and grants from organizations such as the Robert Wood Johnson Foundation. And unlike other efforts that have really been top-down, this has also been bottom-up and top-down and has resulted in collaborative efforts. So we're seeing substantial impetus coming from hospitals and hospital associations, as well as from patient advocates and advocacy groups. And together we will find the right medium to advance our causes in improving minority health. What we're talking about today is really part of a broader historical effort to address disparities. And it goes all the way back to the Civil Rights Act of 1964. Title VI of the Act stipulated that no person in the United States shall, on the basis of their race, color, or national origin, be excluded from participation, be denied the benefits of, or be subjected to discrimination under any program or activity receiving federal financial assistance. Now, Title VI didn't specifically mention health care, but subsequent judicial and congressional clarification has assured that it applies to most healthcare activities in the United States. And so today, what this has done has created an environment for all hospitals and healthcare organizations to collect information on patients' race, ethnicity, and spoken preferred language. This has expanded the role of federal programs and medical service mandates that healthcare agencies must collect this information and report on this information voluntarily and have training and technical assistance to optimize that. There are now standards being developed for data collection, and in 1999 a report of the U.S. Commission on Civil Rights criticized that those lack of resources and failure to collect and monitor data regarding enforcement related to that Title VI of the Civil Rights Act has been a big problem. So our hope is that as we develop these standards, we will have a unified system of understanding the scope of the problem and then be able to address it. Some might ask if we're making progress, and I feel that we are actually making significant progress. And what's different today than in the past is that we're seeing a convergence across all the areas, whether it's regulatory, payment, and other ways that the healthcare delivery system interacts with itself and with government. So for example, the Joint Commission the state health department, meaningful use, all of these initiatives that are coming down the pike all say the same things. We need to collect high quality data on race, ethnicity, and language. And when we get consistent about these definitions, we need to improve the quality for the weakest links in the system. As we improve these quality failures of the healthcare delivery system, consistently they apply most to racial and ethnic minorities, we will see all boats rise. So I'm confident that as payment reform, the Affordable Care Act, the mandates around meaningful use, additional surveillance measures, things coming from the patient-centered medical home movement, across the spectrum, all of these vectors are pointing in the same direction. And so our hope is that in the near future, we'll see rapid improvements in the health of minorities and see that 4 to 6 year longevity difference shrink to nothing.
Well, Dr. Shah just kicked things off by providing us with a detailed look at the existence of health disparities and the health care disparities in this country. Also, the importance of addressing the problem. So, Dennis, I want to start with you and ask you to tell us from your perspective, why are health disparities, the recognition of them, an important priority for hospitals?
Well, Benita, this has been a significant problem of long standing, so it's persistent even as we recognize the importance of recognizing and dealing with disparities. When they are unrecognized and unaddressed, it blocks or interferes with the provision of good care and good outcome from that care. So it's tied directly to how effective hospitals are in providing treatment to individuals. Problems are missed or ignored or dealt with ineffectively. There's increased morbidity and mortality as a result, and there are poor outcomes, meaning poor health care is being provided. So disparities, despite this recognition of their importance, have continued over a number of years. And the landscape is getting a bit more complicated because it's not as if disparities take place or occur in a vacuum. So while your introduction and Dr. Shah talked about the emergence of racial and ethnic minorities or individuals with disabilities, that's a continually changing dimension for hospitals to deal with because it's evolving. And you can imagine how difficult it might be for a hospital situated in a community with a large influx of immigrants from other places, and how do you sort of keep up and deal with it? So awareness is critical to this because it's tied directly to how effective a hospital can be in dealing with its patients.
So then the natural next question would be, how would data collection efforts improve this situation?
Well, you know, Peter Drucker, the management expert, said if you can't measure it, you can't improve it. And so, you know, hospitals have been collecting information for a very long time. And the issues have been standardization, consistency, objectivity, and how that information is collected. So it's critical to ensure that we address those problems. It's also critical to ensure that hospitals and everyone collecting this information and using it understand how important it is. So at the same time as we press for, you know, resolving those issues of standardization and what elements are we collecting and how, it's important to continue to emphasize disparities as an issue that needs awareness. A better understanding of patients individually helps you better understand the community and the circumstances that patients are in. It helps you develop patient-centered interventions to deal with those problems. And you can then measure your success in reducing or eliminating it. And, you know, along the way, you adjust and recalibrate when it looks like the particular interventions you've chosen to put in place are not getting the results you want.
What about looking at population level patterns? Will quality data give us more information in this area as well?
It will. You know, public health has really been based on looking at the health of a community or a population. Hospitals more traditionally have been focused on dealing with that individual patient and providing the treatment and the cure. These ideas are blending more and more as the way hospitals are evaluated, measured themselves, how reimbursement is being designed, how new models of care are evolving. You know, more and more now hospitals are looking out at the community as part of what their responsibility is. You know, you can understand that if a hospital's reimbursement is partially measured on, you know, whether there are readmissions of patients into that hospital, you then understand why hospitals now are so concerned about what's the community environment that a patient is going back into. Do they have the necessary supports and connections to care? So it's understanding these health implications beyond just the individual patient. And that's leading to these emphases that Dr. Shah talked about with population health and the prevention agenda.
Right.
And so it's really this shift that's taking place.
That whole medical home model, and as you
Correct.
used the word reimbursement a few times. So what's the business case, and that's really what we're starting to talk about here, for devoting time and effort to collecting the higher quality standardized demographic and language data?
Yeah. Well, every healthcare provider, whether you're a hospital, a physician, a nurse, a social worker, wants to be effective and wants to achieve good outcome for their patient or the population that they're responsible for. You know, understanding the circumstances of the individual patient and the community and the challenges that are embedded is now an essential ingredient to good care and good outcome. And we are moving as a system from one of volume to value, meaning that, you know, our whole system is now being designed not simply to produce a series of widgets, not to deliver a number of services that drives reimbursement, but to focus instead on outcome. And are we getting the value from healthcare that we should? And so this means that how effective you are is affecting your reimbursement. It'll affect how payers choose whether or not to do business with you. It will affect how patients decide what institutions they're going to use. So the business case really is that better outcome from better and more effective care provides the return on investment.
Now, one of the things that you mentioned was a willingness to conduct self-analysis in order to accurately understand a problem. We had the opportunity to speak with Dr. Stephen Safier, the president and CEO of Montefiore Medical Center, about the steps they've taken to collect better data and provide better patient treatment. Let's take a moment to hear what he had to say.
So I'm Stephen Safier, or Dr. Stephen Safier, and I'm the president and CEO of Montefiore Medical Center. Racial and ethnic data are critical for outcomes when you're dealing with diverse populations. In fact, they're probably critical when you're dealing with homogeneous populations, because you really need to know the people you're caring for, what the community is about, who they are. I mean, it really is everything from what a population is susceptible to, what a population's experience is, which may change over time, and the different strategies you may use to treat different subpopulations that are all living in a wonderful state like ours, New York. I can't speak for all hospitals, but in general, people do collect race and gender. At Montefiore, which serves the Bronx and Lower Westchester, these two areas have 2 million people, and it is a majority-minority community. And we pride ourselves on really doing a good job of collecting important data and using it more and more for care management to keep people well. And a few years ago, we were in a Robert Wood Johnson demonstration project that had to do with the impact of race on heart disease. And when we took a look at our own processes in terms of data collection, we actually saw that we were not doing a very good job. So let me tell you what we found. When people come in to get care and they're new to the system, they register. And that's common, it happens, you know, there's a series of questions they ask you, they try to figure out what your insurance is, or if you don't have it, can we get you insurance? And a series of questions have to do with your ethnic background, your religious background, and a whole series of other issues that would define the community you come from. And just on the race issue alone, what we learned was that our people were eyeballing people and deciding what background they came from. But those eyeball impressions that are made upon people are often inaccurate. So we turned it around, and instead of eyeballing people, we have trained the people that register individuals at Montefiore new to the system in just asking a question, you know, about your background. And it even surprised these experts at registering the answers they got, because people really describe themselves differently. And they know who they are, and they know where they came from.
Okay, so as we build this morning, Dennis provided us with a solid framework for why we're having the conversation, why data collection efforts are so critical to improving the existing health care disparities. And then we heard from Dr. Safir, who gave us a great example of what his medical center is doing and how it's benefited their practice. So David, you're going to be talking to us today about opportunities for New York to improve racial and ethnic data reporting. Give us a rundown of the topics you want to cover.
So, Benita, I'll be giving some information on background why disparities matter in healthcare, how quality and disparities intersect, how to perform race and language data collection, and interventions and the road forward.
Okay, so why don't you start by talking to us about what healthcare should be? You know, in an ideal state, what are the characteristics of a good healthcare system?
Well, the Institute of Medicine has a report called Crossing the Quality Chasm, and they identified several key issues: safe, effective, patient-centered, timely, efficient, and equitable care. And when we talk about healthcare disparities, we're talking about gaps in or the inequities in patient-centered care.
Now, we've all heard the word disparities, but what does it refer to in this context?
Well, in this context, it refers to the differences that exist between specific healthcare populations and the delivery of healthcare that they receive. Mm-hmm. And disparities in health specifically are related to patients' social capital, their wealth, their education, their nutrition, and also the healthcare that they receive.
Do we start looking at disparities in the incidence, in the prevalence of mortality and the burdens of disease, adverse outcomes, things like that as well?
That's right. So those would be typical measures for health.
How is it that different than health care disparities?
Well, healthcare disparities refer to differences in the quality of healthcare that people actually receive and that are not related to access or clinical needs, preferences, or appropriateness. And on the flip side of that, it has to do with the differences in treatment provided to members of different racial or ethnic groups that's justified by their underlying healthcare conditions. So, for instance, that could include both under or over treatment.
Mm-hmm. So that if somebody who is perhaps of a minority, they may not be getting the aggressive care when it comes to, we see sometimes with women in mammograms and breast cancer
Or
treatment.
they may be receiving over-aggressive treatment because people don't understand what they really want.
Now, the two definitions seem closely tied together in a number of ways. Why do we need to break apart the definitions?
Well, we need to break them apart because from the standpoint of health and societal needs, they're both societal needs and medical needs. And we need to be able to focus on these. So even in an ideal world, if we were to eliminate healthcare disparities, there would still be health differences. And so we in the healthcare profession need to do our part to reduce disparities. Mm-hmm.
Now, this is not a new area because there's been research done, significant reports have been published documenting the disparities in healthcare. Would you tell us a little bit about that?
Well, since the original reports that were done, there have been a number of reports by the IOM and the Agency for Health Research and Quality that have outlined disparities in healthcare by race and ethnicity.
Mm-hmm. What are some of the major areas of concern that have been identified through studying the disparities that exist?
Well, they extend across the full spectrum of health care, and these include both ambulatory care and institutional care, primary care, and specialty care, covering just the whole range of health care.
Would you talk to us a little bit about some examples of racial and ethnic healthcare disparities that exist for patients who have health insurance?
Well, this is actually quite important because we like to think that health insurance is a great equalizer and improves access to care. And in fact, even for people with health insurance, there are still healthcare disparities. And they, again, cover the full spectrum of ambulatory and inpatient care and specialty and primary care. So insurance is not just the answer to reducing disparities.
So what are some of the reasons given for the existence of these disparities?
Well, patients and providers and organizations have all a role to play in this. So from the standpoint of the patients, we would like to think of them as having a patient-centered, equitable access and role in the governance of healthcare. So we'd like them to be a part of healthcare decision-making. So when they don't have that, so knowing what they're able to do is actually quite key. And providers are the agents for those patients. They provide them both in terms of how to communicate healthcare information and as well as how to guide the patients through towards specific decisions. And finally, the organizations are critical because they facilitate the types of healthcare that are available to patients and providers. So the same doctor and patient in different settings will make different decisions. So for instance, if I see a patient in my clinic, I may provide them different kinds of care than they might otherwise receive if I saw them in the emergency room or the hospital or a county clinic. And so, you know, before we go ahead and try to design interventions, we have to better understand the problem that we're dealing with and collect better data.
Because you would have a 360 of where they are in their life.
Exactly.
But let's talk a little, what would designing, talk a little bit about an intervention, you know, what would it look like?
Well, from the standpoint of for reducing healthcare disparities, what we'd like to know is, first of all, who our patients are, and then we would decide whether or not there are actually disparities existing for that particular type of care. We would like to be able to focus in and make an intervention, for instance, that would standardize care regardless of whether a patient has of any kind of background. So for instance, making sure that they got a flu vaccine. Everybody should be approached in the same way.
Mm-hmm. There is a sort of a blueprint that we're looking at on our screen right now that gives us a sense of that, where you go from detecting and then you go to understanding and then to redirecting.
Right. So my colleague Amy Kilborn has come up with a general framework for this, for detecting, understanding, and reducing healthcare disparities, and this is based on a public health model. Mm-hmm. But in order to make it work, you actually really need good data.
As we move along, what would be needed from hospital leaders to follow this kind of framework?
Well, the first task that we need is high quality data. And in order to affect change, what we need from healthcare administrators and hospital leaders is to be able to discuss whether or not there are disparities within their own institutions. So, you know, physicians and healthcare leaders are committed to doing the right thing, but they've been, in the past, reluctant to consider that there are gaps in care at their institutions by demographics. So consider if, as Dennis had mentioned, if a hospital is trying to reduce readmissions as mandated by Medicare for reimbursement, and a certain group is disproportionately impacted by this, then shouldn't decision makers focus in and clinicians focus in and be interested in reducing these disparities and making this an area for them to make as their focal area.
Mm-hmm. You make the point that it's important that hospital leaders are willing to gather the data, number one, and then examine the evidence. Why is it so important that they have an understanding of the data they've collected?
Well, in order to make decisions, they actually have to have the data to make an intervention and to measure the impact of the intervention.
Robert Wood Johnson Foundation took a look at this, didn't they?
They funded a set of surveys that looked at attitudes towards an acknowledgement of disparities. And what they found among a set of healthcare providers, starting off with hospital and healthcare leaders, is that when they asked them about their perceptions, many of the participants did not recognize that there was even a problem. So not in my backyard is kind of how they put it. And they didn't believe that disparities even existed within their own institutions. And if they did, that the disparities were actually beyond their control.
Do they also have to acknowledge that there may be disparities, and is that a problem as well?
Exactly. Well, I think from a marketing standpoint, you wouldn't want to tell your community that there are problems based on who you are rather than how sick you are. Mm-hmm. So in order to reduce disparities, there actually has to be recognition and admission that there's actually inequitable care to start off with.
Do you think, or does research show that different types of practitioners are likely to have different levels of awareness regarding the disparities that exist in their own practices?
Sure. So the Robert Wood Johnson Foundation funded and created and funded a set of surveys, and healthcare is like a pyramid. So primary care providers are closest to their patients, and they recognize that there are disparities. And as you go up the chain up to surgeons, they're the least likely to recognize that there are actually healthcare disparities. They're the farthest away from actually seeing patients in the general population.
So taking that the next step, in that pyramid that you just talked about, primary care physicians would be the closest to the general population. Would that mean then that the hospital leaders are at the top and subsequently furthest removed?
That's right. So in other work that was funded by the California Endowment and working with the National Quality Forum, they found that hospital administrators were the least likely in the hospital to know about race, ethnicity, and language data collection. And this is pretty important because in order to make change, they actually have to know the data that they're collecting. And since they're already collecting the data, they can actually identify and reduce disparities.
Now, the disparities that exist, they've been well documented, true?
That's right. So in study after study, what we've seen is that there are racial and ethnic disparities in healthcare. So you can see that there are many different studies, and what our healthcare leadership needs to know is that we're already tasked to collect these data, and so that allows us to identify and reduce disparities.
So it would seem to me that if we already know these disparities exist, the time is at hand for the hospital leaders to start expanding the conversations, to talk about how to improve the quality of care to all patients.
That's right. So race and ethnicity should be part of the general framework of quality initiatives to improve quality at hospitals and other healthcare centers.
But as you point out, you still have to recognize.
Exactly.
The research may be there, you've got to recognize it and recognize that it exists in general. Our focus today, David, is on efforts in New York State. But when we look at the broader picture of hospitals across the country, what do the data collection efforts look like?
Well, nationally, only 82% of hospitals are actually collecting race and ethnicity data. That includes everybody. Here in New York State and in California, where I'm based, it's actually mandated and required. But nevertheless, there's a funnel effect between the data collection and data accuracy and subsequently the trust in that data and how those data are used for quality improvement purposes. So without standardized, reliable data collection, the data can't be used for quality improvement. So the sort of the don't ask, don't tell doesn't work for valid and reliable collection of data in this area.
What do you find are some of the barriers that get in the way of collecting that data?
The biggest barrier is actually staff reluctance to collect the data. So their hesitancy to actually address, actually ask patients about this. The other issues that have been identified are much less important in the grand scheme of things, simply because data collection are mandated, and so legal patient concerns and legal concerns actually need to be addressed and clarified, but they're actually not barriers per se for the data collection itself.
Do you think that staffers know that it's mandated, and so those other concerns shouldn't exist?
Well, that's what we're here to talk about today, and the state of New York is doing a great job in facilitating and providing resources to make that happen.
And you also argue strongly for standardized measures, as you've been talking about.
That's right. So that's part of the mandate, but the mandate isn't enough. So part of that is training and guidance, and the state is doing a good job with that.
So talk to us a little about the importance of standardization.
So standardized measures allow for comparison trending across institutions and regions. It allows us to actually pool data. So the state of New York, Sparks, collects this data for the hospitals and surgery centers and emergency rooms. And so it allows us to actually make these sorts of comparisons, in fact, not just in New York, but across the country.
And how should this data be measured? How should it be obtained?
Well, you know, one of the issues that we note is that there are a lot of objective data that we collect in healthcare. So patient's name and their age, their birth date are pretty straightforward, but race and ethnicity, in fact language, are self-report. And so this is huge because this is one of those things that you really actually have to ask the patients what it is that their race, ethnicity, and language are. So if a patient is unable to answer that question, or they're a minor, if they're a baby, then you need someone to answer for them, a caregiver or a parent. And current law states that hospitals must collect race and ethnicity data that are actually consistent with OMB, Office of Management and Budget standards for race and ethnicity. The state of New York already does that.
And the current OMB standards for race and ethnicity would be what?
They reflect two measures, Hispanic, Latino ethnicity, and a 5-category race measure, which reflects white, black, Native American, Asian, and Pacific Islander. And progress has been made into incorporating the categories into standard government data collections, but there's a lot of heterogeneity across local, state, and federal governments. And so, you know, for quality improvement, the basic OMB categories are not really sufficient to illuminate disparities and target quality improvement efforts efficiently. So I'll give you an example. So if you're Hispanic, your health and healthcare issues may be different if you're from the Caribbean versus if you're from the the mountains of Mexico, or from Central America or South America.
So you really have to get in a little further.
For sure. And of course, if you want to serve your community, you'll want to know who they are. So in California, most people who are Latino are Mexican in origin. Here in New York, it's mostly Puerto Rican and Cuban and Dominican. So it's very different.
David, if the OMB standards are insufficient, what's the recommended course of action?
Well, the Institute of Medicine convened an expert panel, and what they did is they reviewed all of this information, and they really hit it on the head. So what they said is that hospitals, healthcare organizations have to have data, granular data, on information on race, ethnicity, and language, so that they could serve and identify and serve disparities and provide high quality of care to their patients. So what that means is that the granular race, ethnicity, and language data have to reflect the specific needs of the community. And it makes sense from an equity standpoint because and it makes sense from a business standpoint because you really have to know the patients that you're serving in your community.
So as you're crafting your data questions, you've got to know your community and delve in a little further than just stick with those 5 that OMB put out.
That's right. That's right.
You've really got to get your hands around
so
it.
So, if you live if you live in Little Moscow, you want people who can speak Russian.
How has the implementation of the Affordable Care Act affected the recommendations of the Institute of Medicine's recommendations?
Well, everybody's familiar with the insurance exchanges and everything that's been going on currently, but the Affordable Care Act has actually moved the bar in 2 ways. One is it's directed Department of Health and Human Services and the federal bureaucracy to establish data collection standards that move beyond the basic OMB standards. And then secondly, furthermore, it's instructed them to disseminate these standards to federally funded national data collections and to use these standards in reporting out the results of these studies. So, you know, where there are national data collections in place, we're actually implementing these standards.
I was going to ask, and what about for the areas where there are already these national data collections in place?
Right. So we're very fortunate here in the United States to have really good national surveys. So the National Health Interview Survey is implementing this, and then and that's run by the Centers for Disease Control and other studies. So from the Census Bureau, the Current Population Survey and the American Community Survey, which are well used by demographers and others for establishing need and for planning purposes, are also implementing these as well.
That's kind of macular. Let's look micro, and what about reporting here in New York State?
Well, here in New York State, the state has mandated a number of changes that embrace these standards. So what they've done is they've embraced the CDC categories, which are for more granular race and ethnicity measures and include patients' heritage, countries of origin. And they're allowing for the other major OMB recommendation, which is allowing for more than one response. So it recognizes our multi-ethnic heritage of many people. And so it allows people to self-identify up to 10 race and ethnicity, reflecting where their families come from. And it allows individuals to express mixed heritage.
So what's the road going forward from here look like?
Well, what I want to describe at this point is how race and language, ethnicity and language data are collected, and really how the hospitals are going to be able to make interventions along the way, and how the state of New York is going to be monitoring things.
So if you could help explain the process of how the information then gets from the patient to Sparks.
So currently, the way this works is that the point of entry for a patient is their registration with the clerk. And that's either the clerk or the registrar, and they actually collect all the demographic information. That information goes into the hospital registration system and makes its way into the medical record. For the purposes of abstracting clinical information, health information technicians actually take that one step further and enter that in, and that data get combined into a record abstract that gets reported on to Sparks.
Okay, I know we collect the information. You might say that's the first step, but what would you say is the first step in all this?
Well, the first step in actual data improvement is to and what we've been talking about is to standardize race and ethnicity categories. And fortunately, here in New York State, it's already been mandated, and there's a lot of guidance going forward, both for standardization, materials, and training.
Once you have the standardization, what's the next step?
Well, it's to optimize self-report of race and ethnicity, and as I mentioned, this includes the development and use of materials for training purposes, actually performing training, dissemination of materials, and other improvements. And those other improvements actually really move into the 21st century. So those include things like allowing patients to self-enter data either in the hospital or via the internet by a portal to a secure portal to a health information system. So New York State is embracing, I think, many of this approach and is providing guidance in order to make this happen.
Does that help with the reluctance of the frontline staff that has, served as a bit of a barrier, as you pointed out earlier?
Well, I think Marcia is going to talk a little bit about some of the training, but this has been the experience, the cumulative experience that training the staff can make a huge difference in improving the data collection.
And then, as you pointed out to the second step, how do we use this to improve feedback to hospitals?
Well, the biggest challenge with ensuring data quality is actually being able to audit the results themselves. And so it's very hard to get self-identified information for patients for self-report race ethnicity. So some of the processes that we want to put in place are to identify and use standards for data audits and to improve the current data audits that are in place. This is pretty technical, but the other is to identify both potential gold standards. So the hospitals themselves can do this kind of audit, both by sampling their patients, by asking the questions again when the patients come back to the hospital, either readmission or in their outpatient clinics. From the standpoint of the state collects a lot of self-report information, and they can leverage that information and use it to compare to the information that's already reporting by the hospitals on these same individuals.
Start looking back and forth at it. What's the next step?
Well, and the results of the information can be fed back to the state, to the hospitals, to let them know how well they're doing. And that's important because, again, as we mentioned before, that administrators tend not to know what the data that they're collecting. Well, they are even less likely to know the quality of the data that they're reporting. And then finally, you know, essentially at this point we're pretty much done, but there's always gaps in information and incomplete data. And so supplemental sources information that I mentioned before could be leveraged and used for improving the data quality that are reported and collected by the state. So the state itself can actually use data that it already has.
A little redundancy is not so bad.
Not so bad in this case, that's right.
Yeah. And what are some examples of supplemental sources of self-reported data?
Well, you'd be surprised, but there's quite a bit. So the state, as I mentioned before, collects data going through to the hospitals, but then the cancer registrar collects data. Most cancers are identified in the hospital, so there's a lot of duplication among those patients. Patients who die, they have death certificates submitted. Births also are reported out to the Department of Public Health. And in fact, for moms, this is really important because they are the ones who are filling out the birth certificates, and we can compare what's on the birth certificate for what the mom reports for her race, ethnicity to what the hospitals report at the time of birth in the deliveries. So we have a lot of information. In fact, there's other information that's not healthcare information that we could even leverage as well. So there's a lot that could be done that would help for data accuracy.
What's the final step in all this?
Well, you know, there's once we have self-reported information, there's actually also indirect methods that we can use for improvement. This is very technical, but there are statistical methods for projecting out race and ethnicity based on patient's name and where they're, and granular geocoded data. And this is an approach that even Medicare has used, as well as private insurers who in the past haven't collected information on race and ethnicity. But this is actually a sort of a last step, and it doesn't replace the actual collection of data. So the current efforts in New York State are the gold standard, and I believe that what they're doing is consistent with and towards achieving actually good results.
Where do you see us going from here?
Well, the road forward is actually pretty clear, and we have a lot of, the state of New York is providing a lot of guidance in the implementation, and there's substantial experience and information on making the implementation a success. So nationally, there are good materials for training, and both through the HRIT toolkit and what work that we've done in California. And so there's a lot of information that can be used and employed here in New York State. So I think that the information that's collected is going to be really good quality and can be leveraged for making healthcare and better and disparities decrease here in the Empire State.
David, thank you. Wonderful information for us to contemplate, look at today. Marcia, you're up. Your turn. You're going to be talking about efforts made by the Robert Wood Johnson Foundation, correct?
Yes, that's correct, Benita. I'm going to highlight some work that we've been doing in disparities, but one program is Aligning Forces for Quality. We call it AIA for Q, and it's the Robert Wood Johnson Foundation's signature effort to improve the overall quality of healthcare, reduce racial and ethnic disparities, and provide models for national reform in 16 targeted communities across the nation.
Okay, let's take a more in-depth look at that.
Okay. While healthcare quality is a national problem, healthcare is delivered locally, and then that means it needs to be fixed locally. And in each of these 16 AIA for Q communities, there's an organization that brings together people who give care, physicians and hospitals, those who pay for care, employers and health plans, and those that get care, patients or consumers. And all these stakeholders work together to improve the quality of health care in their community. Now, the AFRQ communities are quite diverse. Some are actually entire states like Maine or Minnesota. Some are single counties like Humboldt County in Northern California. And others lie somewhere in between, like here in Western New York, where there are 8 counties that come together as a community that includes the city of Buffalo. And while they're all working on overall healthcare quality, I really want to talk a little bit more about their disparities work today.
When you talk about these communities and how they can be so diverse or not, are you talking only about the disparities in hospitals?
No, actually they're looking at disparities in several settings, including hospitals and in the ambulatory setting as well. But we've had a lot of efforts that did focus on hospitals. At the National Program Office, we've led a number of collaboratives that included hospitals across all 16 of the communities, and each of those hospitals was expected to standardize the way they collect race and ethnicity data. Now, some of the efforts in hospitals are local, like the Greater Cincinnati Health Council, which is working on disparities in their hospitals in southern Ohio and across into northern Kentucky. Now, over the years, the National Program Office has worked with over 200 hospitals in the standardized collection of race and ethnicity data. But at the beginning, the real foundation was a program called Expecting Success, also funded by the Robert Wood Johnson Foundation. And it was a 10-hospital collaborative to address disparities in cardiac care. And it was so good to hear from Dr. Safier today because Montefiore Medical Center was one of those hospitals.
Who needs to get involved to address these disparities in a significant way?
Senior leadership is key. They have to be engaged, and that's because they can do 3 things. First of all, they determine organizational priorities. The CEO can say disparities is going to be a priority in our organization. Once they declare that it's a priority, they can allocate the necessary resources. For example, the time and money to appropriately train the staff, the registration staff. And then the third thing they can do is they can remove barriers. So now that New York hospitals are going to have to be collecting more granular categories, they are probably going to have to make some changes to their information technology, their IT systems to capture this data. The CEO can say to the IT department, this is a priority, this change needs to go to the top of the to-do list. The other thing that needs to happen is we've got to get provider-level data. Say, for example, the state of New York says, we have disparities, and they show state-level data. Well, who owns that problem? As David said, you've got to be able to push that data down to the level of the provider, because if not, you run into a problem we call assumed equity. And that's when hospital leaders or healthcare leaders think that disparities exist, but not in their organization. And because they believe they treat all their patients the same, they assume the care is equitable. Once you have provider-level data, you can have the difficult discussions about potential disparities, and should you find a disparity, it can move you to action.
And where action's been taken, Marcia, were there specific steps that were followed during the process?
Absolutely. We use a 3-step framework. It comes from the Institute of Medicine, and it mirrors exactly the framework that David mentioned before by Kilborn. You collect the data, standardized data, you stratify and analyze the data, and should you find a disparity, then you can act on that difference.
As with any change, I'm sure there were challenges.
Yes.
People don't like change.
Very difficult.
You want to talk about some of the challenges you face?
Sure. Across this 3-step framework, we found 8 challenges. In the first step, the standardized data collection, the #1 challenge was staff anxiety. Staff are uncomfortable asking these questions. The second challenge was which standardized categories should we use. Now, the hospitals in New York are fortunate. They're not going to have this problem because they've been given the set of categories to collect. And then the final challenge is making the necessary change to the IT system to collect the new demographics. And again, this is where you need to have that CEO leadership who can remove that barrier.
Buy in there first. Were there challenges regarding the stratification and the analysis of the data?
Absolutely. And one of them has to do with data collection versus data analysis versus data reporting. And let me explain what I mean by that. In New York, the hospitals are now being asked to collect more granular categories. Some hospitals may elect to even collect more granular than what's required. So they collect all these granular categories, then they collapse some of them and report those categories to the state of New York. And then the state of New York, in doing an analysis, may need to collapse categories a little further. And this is the issue with collecting more granular data. We're big advocates of collecting more granular data because we think it's more patient-centered. That patient has more choices. Plus, it gives the organization much more accurate information about its patients. But when you have granular subcategories, you can get into some pretty small numbers in some of those categories. So when you go to do the analysis and compare different groups, sometimes you have to roll up to broader categories. So that's the challenge there.
And I would just say that granular categories may be for the audience, may be a weird thing to say. And what we're really trying to say is, know your patients and where they're from. And so what's good for one hospital organization may be a very specific subgroup of people from a specific part of the world, and so it's good for them to know who they are.
When we started talking about this and you started using the term granular, all I could think of was sand.
Yeah.
Well, sand may all look like the same thing until you start looking at each individual pebble, and they can be quite different.
Right.
And the makeup of that, and that's what you're talking about, and not just looking the broad brush,
right,
but really understanding, as Marcia said, the patient that you are dealing with.
Right. The state of New York is creating guidance, and the categories that they're providing are general categories and even pretty specific subcategories, but what's good for a specific provider may not exactly be in what they say you have to collect, so you can go beyond what they're saying.
And then I have to wonder, given that, Marcia, were there challenges regarding once you've identified the disparity, what were the challenges then?
Right. Well, not surprisingly, once you find a disparity, what surprises a lot of people, Benita, is the data give you a lot more questions than they do answers. Once you find a disparity, that's when the real work begins, digging through the data and talking to your patients to find out why those differences exist, almost doing a root cause analysis. And then figuring out the intervention that's going to reduce that disparity. Now, David talked about the big body of evidence we have documenting disparities. Unfortunately, the body of evidence on the interventions to reduce disparities is much smaller. There is some good work going on. One program in particular, Finding Answers, also funded by the Robert Wood Johnson Foundation, is actually looking at which interventions can reduce a disparity. But let's just say that's a work in progress. And then the last challenge is one that Dennis mentioned earlier. In healthcare organizations, they can only do so much to reduce disparities if they stay within their four walls. And at some point, they've got to reach out to the community. They've got to develop partnerships with community organizations because that patient's health moves into the community. And I think under the Affordable Care Act, for example, the community health needs assessments that the hospitals are going to do is going to help them build and strengthen those relationships with the community. So that's a great first step.
I have a feeling we're all going to suspect the answer to this. I'm going to ask you the question anyway. Of all the challenges, which would you say was the greatest?
Number one, staff anxiety. It's just a difficult set of questions to ask. Now, the solution to that is you've got to take the time to train your staff properly, even if it takes you months to get through all the staff training. Now, the good news is there's a great toolkit out there, and David mentioned it earlier. It's by the Health Research and Educational Trust. HRET is the research arm of the American Hospital Association, and it's a wealth of resources that hospitals can use. Another thing we recommend is tell your staff the reasons for collecting the data. Let them know this is important. It's not just one more thing that they have to do. Secondly, if you learn something about your patients, tell your staff, because then they understand why it's so important to collect the data. And finally, monitor staff. Don't just train them and walk away. Make it part of their annual review where you monitor and make sure they're following the policy of actually asking the question.
Marcia, is there evidence supporting the idea we're getting closer to closing the gap and eliminating certain disparities?
There has been some progress in some hospitals, and we believe that some of the keys are not just looking at performance measures in the aggregate for all patients, but having the ability to stratify or break down those performance measures by race and ethnicity and compare different patient populations. One of our hospitals, in Expecting Success, learned that they had a disparity between Hispanic and non-Hispanic heart failure patients receiving discharge instructions. They had no idea that there was such a difference. they were able to close that gap, eliminate the disparity, because they could see where there was a problem, figure out what was causing it, and then make sure that all their patients were receiving the same quality of care.
Do you have examples for here in New York State?
Actually, we have a great example here in New York State. It's in Western New York. It's called the P2 Collaborative. And they've undertaken a project where they're working with 10 safety net clinics. Now, these clinics serve very diverse patient populations, high number of Medicaid patients. And what they've done is they've drilled down to 3 clinics. And in those clinics, they're improving the quality of race and ethnicity data that they're actually collecting to make sure that they don't have disparities. And in the meantime, they're also trying to develop what we call a culture of equity in those clinics. And this means that disparities isn't something you do in addition to regular quality improvement. Disparities has to fall under the quality improvement umbrella. And when you've got leaders who recognize that, providers who recognize that disparities represent a failure in quality, then you've taken an important first step towards moving towards a culture of equity.
Which brings me to ask, once the hospitals have the data, what can they do with it?
Anything they want, and that's the great part about this. No matter the reason for collecting race and ethnicity data, once you have data on your patients that you can trust, you can look at anything and any group, any different groups of patients. So for example, one hospital looked at 30-day readmission rates across 4 different conditions, and then they broke it down by patient race, ethnicity, and preferred language. And this hospital saw some interesting differences between groups of patients, and they learned a lot about the readmission patterns in their hospital. This data gave them a whole new set of questions to look at in terms of quality of care, and that's powerful information.
Once hospital, administration recognizes, and they don't say, not in my backyard, and they say, okay, maybe we do have the problem, and we're going to get this data. Does the hospital then have to say, okay, but now I've got to put on a whole nother staff in order to best evaluate this data so that we can figure out what to do with it? Or is the staff already in place to do this?
And that depends on the institution. If they're already looking at disparities, they may have staff whose job is to do the analysis. But that goes back to what I said about senior leadership buying in. They then need to allocate the resources to make this happen. And besides training your frontline staff, it can be allocating the full-time equivalents or the employees to do the analysis and then to actually figure out what the problem is, which, as I said before, involves digging through the data. Hold focus groups with your patients and ask them what the problems are in them not getting this care. So there are resources that have to be allocated once the senior leadership make this commitment.
And then I want to go back to when you talked about, and you've all touched on staff involvement and staff pushback, and that once you bring the staff in, this starts to really, you get the information that starts to flow. Does the staff then feel empowered to explain to the patient why they're asking these questions? Because we have a culture where being asked these questions sometimes becomes off-putting.
Yes. Well, the important thing is that should be a part of staff training, and the HRET toolkit has some suggested language. There's research that suggests what language might resonate with the patients. But more importantly, that each hospital should take these training materials, take these scripts, and make it work for their organization. So for example, it may be part of this organization's mission. So when registration staff talk to patient, they should be talking in the language of their hospital or their clinic where they work. So you take the tools, you make the scripts match what your mission is and what staff are comfortable with, and that becomes part of their training and asking the question.
And then I want to bring Dennis back into the conversation here, because this really speaks to what you said in the beginning in terms of the business model and how we have shifted, and patient satisfaction is so key.
Yeah, I mean, we're now in the age of technology. People are used to using Amazon and Yelp to make decisions, and more information is available to individuals through that mechanism that speak to the quality. We've got measures of patient satisfaction being used to measure and evaluate effectiveness of institutions. So all of these things blend together. Now, I don't minimize the challenge for institutions to do this, because it's not only about training your staff. There needs to be some emphasis in the community about this, because when individuals are asked these questions, they themselves have some resistance to the idea of providing this information. So it's a complex, it sounds simple and straightforward, but it has a lot of complexities, and you know, resource allocation is always a challenge. But I think more and more, the fact that we're doing big data analysis, that we're moving more to outcome-based, that patient satisfaction is part of the equation, that this becomes more possible as a legitimate business case for hospitals to pursue.
Before we move on, and I know we've got some questions that you've all sent in to us, Marcia, I just want, if you would summarize some of the key points here, the case for addressing disparities, why it's so essential.
There's a number of reasons that, as Dennis said, why organizations are moving towards addressing disparities. The first reason's been around for a long time, and that is fulfilling your mission. If you see a diverse patient population, then addressing disparities should be woven into the fabric of what your organization does. But there's some other external factors that are influencing hospitals, and I think Dr. Shah used the word convergence during his remarks, and this is really exactly what's happening. It might be because you need to meet a mandate. Now, New York State now has an enhanced mandate. Joint Commission has changed their standards on race, ethnicity, and language data collection. We had meaningful use that came out of the American Recovery and Reinvestment Act of 2009. And then also in improving quality, and we heard Dr. Safir talk about this earlier, is if you collect data where you accurately know your patients, that allows you to improve quality by doing the comparisons, identifying the gaps. And without that information, improving quality, you can only get so far when you look at aggregate data. And then finally, as Dennis said, the reimbursement methods are changing. Medicare is changing how they pay for readmissions. Accountable care organizations are being asked to be held accountable for the health of a patient population. And as public and private sector move towards paying for quality, paying for value, every hospital is going to have this kind of data in order to respond to that.
Now we're going to move to your questions. So this comes to us from Maryland. For you, Marcia, how can hospital-collected data on health disparities be used to represent the community, since the clients that are served by the hospital may be from only certain areas of a community?
Well, I think that's a great question. I think it becomes increasingly more important as we move, as we've all talked, this move to population health. One of the advantages in New York is being able to access data across providers. A single provider can look at his or her data within their organization, and certainly, as we've said today, we expect them to act on it. But in order to look at the population across the community, you've got to be able to combine data sources. That's one reason that standardized categories are so key, because if you don't have standardized categories, can you imagine in a state where the categories aren't mandated, everybody collects different categories. So New York is really ahead of the game, and David talked about this with the different data sources. The categories are standardized, data can be combined across provider, and then that becomes much more powerful in looking at the population in a community.
And you've all used that word about standardized, and that's so important, because otherwise you're collecting apples and oranges and grapefruits, and you don't really know ultimately what you've got. And I want to say thank you at the outset for everybody who did send in, call in a question for us. David, this for you. Do you think that the public should be better educated about the need to collect race and ethnicity data and how it's used? This question also coming from Maryland. I've met many immigrants that the concept of race/ethnicity is not common.
That's actually quite true, and in fact, when folks have their first encounter with the healthcare system and other institutions, and they're asked about race and ethnicity, they have no idea what they're talking about. So in some places, as I've been told by some of my colleagues, where in the Caribbean, they don't talk about that they would be considered African American. They go by their shade of color instead of calling themselves a specific thing. So we do have to educate the community in general about race and ethnicity and language collection. We ask those questions on the census and the American Community Survey. It's not something that's just out there that isn't being collected. But we also have to alert people to to know what we're using this information for. And so this has to do with, we're using this information not to identify people for like what their genetics are, anything like that. We're trying to understand what their preferences are, their cultural identification, where they're from, so that we can better serve their needs and better address what might be happening to them, both when we see them in the healthcare setting and when they're not in the healthcare setting, because frankly, much of what happens with a person's health doesn't happen when they see their doctor.
I'm smiling because I'm seeing a very large group of other being checked. And Marcia, you want to jump in on the conversation.
I should say in California, so if you ask the question to someone who's Latino what their race is, 95% of them say other, and that's because they're mestizo, they're mixed race, they're indigenous people, they have indigenous background, they have European background, they have Asian background. A lot of Chinese immigrants built the railroads in Mexico too.
I wanted to go back to a point that Dennis made about the community being involved, and I think it speaks, Benita, to the question that just came in. In a couple of our AFRQ communities, they've actually had public campaigns to make everyone aware that when you go to see your doctor, when you go to the hospital, you're going to be asked these questions. So what they're trying to do from the community side is make this the norm, make this the expectation. So no matter where you go, Dennis, you know you'll be asked these questions. And I think that's a great complement to what the hospitals are now being asked to do, because we were in Detroit, we were doing some training, and a woman came up to me and she said, I went to my doctor the other day and they didn't ask me about my race and ethnicity, and they're supposed to, and I asked them why. So this is a changing mind shift, a changing culture, if you will. So hopefully, through these companion community campaigns, there can be an increased awareness among everyone about why this is so important.
Dennis?
Yeah, you know, Benita, I think both of these questions speak to the importance of something that Marcia said about combining data sets. So there are a number of sets of providers and organizations that are out there looking at these community questions, and they all have a different perspective. But by bringing those together, we get a much more enriched view of what's going on. And you know, the Department of Health here in New York for several years now has been encouraging and providing incentives for hospitals to work with their county health departments on doing community health assessment. So you have the more traditional role of a county health department in doing public health assessments, you know, relying on different methods of collecting information. CDC does behavioral health surveys. So lots of sources of information can come together and then be enriched by the experience of providers who are interacting with specific patients. So it really is this idea of bringing together a number of sources.
I'm also hearing an underlying issue here of health literacy and language in general. With diverse populations, you will have issues over language. You may even have a child being the interpreter, not a good situation for the parent, and having to get this ethnicity issue on the table in a language that is, I want to use the word understandable, but one that makes sense in someone's native tongue, to know really what you're asking.
Right. Well, the question about language has to do with what is the language that you're most comfortable with discussing medical issues, and so that may not be the same thing as what you speak at home. I just like to add that you know, we're talking about this in the context of a rollout from New York State, and for alerting hospitals and helping them to implement these changes. But you know, frontline staff, there's a lot of turnover, and so my expectation is that this is going to be an ongoing training process, and so hospitals really have to be invested not just in this initial setup, but that they need to be prepared to train and retrain their clerks to do this and registrars to do this, so that the data quality stay good over time. You know, 3 months from now, you know, after the initial wave of people understand this, then the next group is going to have to go through the same process.
Which, Dennis, raises the next question we were sent. How will Haney's support hospitals in making these changes?
Well, we've been working closely with the Department of Health and Dr. Shah on this rollout, both in terms of data collection and in terms of his larger prevention agenda and population health agendas. And Marcia mentioned resources that the American Hospital Association and HRET have put together, and we are, of course, are a close partner with them. So we've been sponsoring a series of educational programs through our organization and working with our membership along these same lines to reinforce and expand upon the effort we're talking about today.
Mm-hmm. Marcia, in your work with hospitals, were there any unexpected partners or community groups that helped support implementation in hospitals?
That's an excellent question. I would say that for the most part, where we saw the stronger community relationships were in the outpatient setting, some of which were part of health systems. So it wasn't as much the hospitals themselves, but as those patients transitioned to the outpatient setting, I think there were more community partners. Now, I think that has shifted. I think since we've been working in this field for about 7 years, we definitely have seen a real shift where hospitals now are more willing to engage more with community partners. But I think historically it's been a little more prevalent in the ambulatory setting.
Mm-hmm.
And you know, hospitals are independent entities, even when they're hospital chains. So I would expect that because of the way the leadership in a particular hospital may be more successful in implementing this type of system within their own facility, as opposed to over a whole system, although I would say that the system heads then would be the ones who would need to make the implementation a success across their entire system.
That was going to be a question that I was going to jump in with. Once you get this information collected and your system going in the hospital and you're utilizing it in the hospital, that's great, but it's great insofar as the hospital. You still have to get it out into the community. And how do you make that happen in a timely fashion? Does it mean partnering, Dennis, with your county health departments?
Well, you know, partnership with hospitals is sort of an increasingly common characteristic these days because of some of the ideas we've talked about, as there's now an increased focus on population health, on health in the community. And you know, hospitals were designed to sort of treat the immediate urgent situation. And it really has been for many years focused on the patient appearing at the door in an ambulance and getting that urgent care and treatment and being discharged. And then that's sort of been the limitation of the responsibility. So, you know, if you're going to get paid, for example, under one of these reimbursement models where you're capitated for the care of a population, then your incentives are all different. It's not just about that. It's about preventing occurrences of people coming into the hospital in the first place, preventing readmission to the hospital, ensuring you have the best outcome to ensure that that happens, that they have connections in the community to provide support and other care. And so increasingly it is about partnerships. And some models in New York, for example, health homes, are designed specifically for this purpose of bringing different types of providers together. And so I think it's an increasingly common event now for hospitals to be thinking about and acting in terms of partnerships with community members.
I think I'm also hearing that there is room, and I think, Marcia, you touched on it, for innovative ways to get this information out there and how to best share it. But New York being established for at least the collection at this point. I love this question, and it's from the Office of Medicaid Inspector General. It doesn't say which state, so we don't know. Okay, would data collection see less disparity if entered into system by medical staff or thus trained? Example, first or second year medical students.
I would just say it's all, again, it's the same thing as the staff. They have to ask the question. And in fact, in current medical training, our trainees are focused less on the social history and asking about the patient. They're still drilling down on the clinical conditions. And frankly, as a primary care provider and a professor, my statement is you need to know who your patients are and where they're coming from, because your treatments are going to be totally unsuccessful once they leave your office if you don't know who they are. So they would have to go through the same training.
And I think that's, you make a great point, David, because so often you have the registration staff who are well-trained, the patient self-reports their race and ethnicity, and then a clinician who may dictate a history and physical and looks at the patient and decides what that race and ethnicity are. So we had one health system where the physicians agreed that they would not look at the patient and decide race and ethnicity. They would actually go back and use the demographics that had been collected at registration. So that was great. It prevented that disconnect from different pieces of information.
I'm
about
going
the
to use
patient.
the analogy to the television show The Voice.
Oh,
Don't look at them. Just
yes, that's right.
Well,
you have to ask them.
And
Yeah.
I would add to that that there's it doesn't matter who asks the question. You actually have to ask the question. So, for instance, if you don't ask a patient about what language they prefer, you may get the clinician will quickly find out that the patient doesn't speak English well.
you just get a lot of this. That's right.
Well, you
have
get a
to
lot
ask.
of that, but if you look at the registration form, you know, they may just be interested in where the patient's name, birth date, where they live, and what insurance they have.
Right. Question came in for clarification. David, healthcare providers need to know their patients so they can provide proper care for them, correct?
Right.
The race and ethnicity may affect the way they're treated or were previously treated. Can you comment on the fact that homogeneous race is declining? Wouldn't their place of origin be more important to decipher the previous care they had?
Well, you know, there's again the collection of race and ethnicity is quite a challenge in a country that's a melting pot. But how we self-identify with regard to race and ethnicity reflect our preferences and our health and our behaviors. So, that speaks to many things. So, you know, there may be a generation ago, if you were Hispanic, you might have just answered that you were white. Whereas now, if you're younger, you might actually be responding that you're Hispanic, and that will reflect what you eat, where you go, and so on. So and you can answer in more than one way. And since it's self-report, in fact, you could report more than one way differently each time you encounter the healthcare system over your lifetime. And so
Then how do we know how to best treat?
well, in this case, it's in terms of the encounter that you see them, it's how they self-identify at that time.
But you may be missing something important.
You might, but this isn't rocket science, right? This is trying to get at how patients behave.
Because the
And
question,
we're trying to help them.
right, overall, I guess the confusion is how the data is collected for those of multiple ethnicities.
Well, so for multiple race and ethnicity, we allow for them, first of all, to identify, even to order their preference on their background. And then there are, in terms of what the CDC and the OMB and the Institute of Medicine have created a general framework for rolling up categories for reporting out to these bureaucratic institutions.
Marcia, did you want to jump in?
No, nothing to add.
And I find this whole multi-ethnicity, and I'm sure many of the people who are sitting in the audience and listening today may identify with one particular racial or ethnic group, but as the conversation goes on, you start to think, well, Graham was really Russian, and my great-grandfather was Greek, and my other great-gram was Hispanic. So I may appear white, but what am I, and how should I be answering these questions as they are asked of me in the future?
Well, I think in part, one of the important things going forward is having the ability for a patient to report more than one choice. And historically, when we had much more limited information technology systems, you could only pick one, and then you couldn't be more than one. And I think as we move forward in the technology and being able to collect you can make multiple choices, which is that is what is happening in America. You need to be able to make multiple choices. I think that's important. Where we're going to have to start doing some work on the other side is then when we go to do an analysis, how do we handle those kind of data?
You may have more than you know what to do with.
Right, right.
And have to decide at some point Right, as you say, what to do with it. David, in California, we had a question. Were hospital leaders surprised at the disparities in healthcare at their institutions or hospitals?
I would say here in New York State, the quality of the data potentially are more granular and even perhaps more accurate, even now. So, so the answer to that is I don't even think they know in their own in my home state, and we're still in the process, going through the same process that New York State is, that implementing and improving the actual collection. This is not a New York State-centered issue. This is a national issue that frankly we're only really barely scratching the surface of.
And I have to also wonder the role that electronic medical records will play in this discussion as your health care, your health records are more easily accessed, more seamlessly as you may travel across the country.
Well, I think Medicare is a great example. When they first came up with race ethnicity categories for Medicare, it was really black, not black. That's the categorization, and so they've spent a lot of time trying to move over and actually use data that they collect through satisfaction surveys to correct that information. But they themselves have a big barrier to overcome because they don't, even on a national standpoint, they don't have good data. So we're trying to move ahead.
Yeah. And we've got about a minute, but somebody wanted to know if you would comment on healthcare in Canada and Europe. Are their health disparities as great as in the U.S., and should we just switch to Canada's system of healthcare? And that's a whole other program. But
well, there's a white paper in England that looked at disparities and addressed sort of they recognizing and how socioeconomic status and the built environment impact health. So they had not only a white paper, but a policy paper on how to do this.
Mm-hmm. And they did take a look. And we have another question. Can you please provide the source to access the HRDT toolkit? Yeah.
If you just Google it, if you go out and Google HRET toolkit and get to their website, I'm not sure of the URL for that, but it's fabulous. They have wonderful resources, but if you just Google it, you will be able to get to that toolkit.
And very briefly, in New York, is there a best practice for working with a racial community that may experience a health or healthcare disparity?
Lots of great examples. We heard from Steve Safier at Montefiore, which has done a pretty incredible job over a number of years in mounting community programs that address disparities. So a wealth of these that I think probably health department would be the best source to get a set of examples across different kinds of providers.
Mm-hmm. And I should point out that if you want to ask a question and you were not able to get that question in during the program, you can still ask it and the staff will in fact get you answers. Because sometimes it's as the doors are closing that we realize that we had something that wasn't addressed, and want to make sure that everybody is able to get that information. For more information about this webcast, as well as how New York State is working to eliminate healthcare disparities, you can visit the link that is up on your screen. We'll leave it up there for a moment so that you have an opportunity to jot that down. It's the improvedpatientdatanys.org, so you can get more info, because this becomes sort of, this is a good jumping off point. You know, it's one to get the conversation going, and there obviously is a lot of work that has to be done to make sure that it's done smoothly, that it's done effectively, that everybody feels that they have a buy-in to it. As I think you all pointed out, if the staff understands the value of this, that it's not merely being inquisitive and not, as I think as you said, Marcia, just one more thing to add to an already busy day, and to understand that this really makes a better patient experience, then you're all on the step to getting to the point of better care for the patients. I want to thank you very much for joining us today. Of course, our thanks to our panel participants. Please remember to fill out your evaluations online. As we mentioned, your feedback is always helpful to the development of our programs, and continuing education credits are available. To obtain nurse continuing education hours, CME and CHES credits, learners must visit the www.phlive.org and complete an evaluation and the post-test for today's offering. Additional information on upcoming broadcasts and relevant public health topics can also be found on our Facebook page. Love it. Don't forget to like us on Facebook and to stay up to date. As a reminder, you can also download the companion guide to this broadcast on our website, phlive.org. The companion guide will provide you with learning activities to help you further your knowledge and understanding of topics covered in today's program. This webcast will be available and on demand on our website within 2 weeks, and DVDs of any of our Public Health Live broadcasts can be ordered from our websites as well. Please join us for our next broadcast, November 21st, as we address human trafficking. I'm Benita Zahn. Thanks for joining us on Public Health Live.
Anyone else have been doing this kind of work more than the outpatient setting, more than nursing homes, and so are equipped to help advance the goals that we all have. We're also looking to get support from state and federal funds and grants from organizations such as the Robert Wood Johnson Foundation. And unlike other efforts that have really been top-down, this has also been bottom-up and top-down, and has resulted in collaborative efforts. So we're seeing substantial impetus coming from hospitals and hospital associations, as well as from patient advocates and advocacy groups. And together we will find the right medium to advance our causes in improving minority health. What we're talking about today is really part of a broader historical effort to address disparities. And it goes all the way back to the Civil Rights Act of 1964. Title VI of the Act stipulated that no person in the United States shall, on the basis of their race, color, or national origin, be excluded from participation, be denied the benefits of, or be subjected to discrimination under any program or activity receiving federal financial assistance. Now, Title VI didn't specifically mention health care, but subsequent judicial and congressional clarification has assured that it applies to most healthcare activities in the United States. And so today, what this has done has created an environment for all hospitals and healthcare organizations to collect information on patients' race, ethnicity, and spoken preferred language. This has expanded the role of federal programs and medical service mandates that healthcare agencies must collect this information and report on this information voluntarily and have training and technical assistance to optimize that. There are now standards being developed for data collection, and in 1999 a report of the U.S. Commission on Civil Rights criticized that those lack of resources and failure to collect and monitor data regarding enforcement related to that Title VI of the Civil Rights Act has been a big problem. So our hope is that as we develop these standards, we will have a unified system of understanding the scope of the problem and then be able to address it. Some might ask if we're making progress, and I feel that we are actually making significant progress. And what's different today than in the past is that we're seeing a convergence across all the areas, whether it's regulatory, payment, and other ways that the healthcare delivery system interacts with itself and with government. So for example, the Joint Commission, the State Health Department, Meaningful Use, all of these initiatives that are coming down the pike all say the same things. We need to collect high quality data on race, ethnicity, and language. And when we get consistent about these definitions, we need to improve the quality for the weakest links in the system. As we improve these quality failures of the healthcare delivery system, consistently they apply most to racial and ethnic minorities, we will see all boats rise. So I'm confident that as payment reform, the Affordable Care Act, the mandates around meaningful use, additional surveillance measures, things coming from the patient-centered medical home movement, across the spectrum, all of these vectors are pointing in the same direction. And so our hope is that in the near future, we'll see rapid improvements in the health of minorities and see that 4 to 6 year longevity difference shrink to nothing.
Well, Dr. Shah just kicked things off by providing us with a detailed look at the existence of health disparities and the health care disparities in this country. Also, the importance of addressing the problem. So, Dennis, I want to start with you and ask you to tell us from your perspective, why are health disparities, the recognition of them, an important priority for hospitals?
Well, Benita, this has been a significant problem of long standing, so it's persistent even as we recognize the importance of recognizing and dealing with disparities. When they are unrecognized and unaddressed, it blocks or interferes with the provision of good care and good outcome from that care. So it's tied directly to how effective hospitals are in providing treatment to individuals. Problems are missed or ignored or dealt with ineffectively. There's increased morbidity and mortality as a result, and there are poor outcomes, meaning poor health care is being provided. So disparities, despite this recognition of their importance, have continued over a number of years. And the landscape is getting a bit more complicated because it's not as if disparities take place or occur in a vacuum. So while your introduction and Dr. Shah talked about the emergence of racial and ethnic minorities or individuals with disabilities, that's a continually changing dimension for hospitals to deal with because it's evolving, and you can imagine how difficult it might be for a hospital situated in a community with a large influx of immigrants from other places, and how do you sort of keep up and deal with it?
Years fewer than whites. Factors that contribute to those disparities include income, education, environment and economic conditions, specific health behaviors, access to health care, and the quality of that health care. You know, on the flip side, certain vulnerable populations actually get the wrong kind of care more often in terms of amputation, in terms of getting their teeth pulled out rather than getting a root canal. These are things that we want to avoid. And ultimately, these differences in health care between minorities and non-minorities are associated with higher mortality. If you look at age-adjusted death rates per 100,000 people, for the 4 leading causes of death in the United States, they are always much higher among blacks and African Americans compared to whites. Heart disease. On average, 247 blacks die of heart disease versus 187 whites. For stroke, 60 blacks versus 40 whites. For cancer, 215 blacks versus 177 whites die. These kinds of statistics are borne out everywhere we look, that ultimately this bad care or inappropriate care or overutilization of the wrong kinds of services consistently leads to poor outcomes for our underserved minorities. So what do we do about this problem? We really need a broad approach that brings in all the players. And what we really need to start with is high quality, reliable data to put boundaries around the problem. So we need data on the race, the ethnicity, and the primary language of patients at almost every point of care. And once we improve the data collection, we can allow healthcare professionals to enhance their ability to interact with patients and provide real-time solutions. As we evaluate their work over time, we will finally start to address the challenges that we really face in every sector of healthcare today. I think we should start with our hospitals for 3 reasons. First, there are many national organizations such as the American Hospital Association, the Association of American Medical Colleges, the American College of Healthcare Executives, and many others who have already started work in this area with their national call to action to eliminate healthcare disparities. Second, New Yorkers recognize hospitals as leaders of healthcare in their communities. And finally, hospitals have an established history of experience with quality improvement and quality assessment. They, better than
some minorities continue to experience a disproportionate burden of preventable disease, death, and disability compared with non-minorities. Therefore, it's clear that as this segment of the population grows, the future health of the nation will be determined to a large extent by how effectively our society works with communities to eliminate health disparities among those populations. Today's webcast will discuss the important and leading role that our state's hospital systems play in meeting this challenge and, in particular, the vital importance of creating a system for collecting standardized racial, ethnic, and language patient data as a critical first step in achieving our goal of health equity. Specifically, our panel of experts will address the rationale for data collection, including the challenges we face related to the design, implementation, and maintenance of a standardized data collection effort. In addition, they'll explain why hospitals, emergency rooms, diagnostic and outpatient surgical centers are logical places for data collection and provide a roadmap for how to begin making the changes necessary to succeed. To begin our program, we're going to hear from Dr. Nirav Shah, Commissioner of the New York State Department of Health. He'll elaborate on why the issue of health disparities is so important.
You know, despite all the advances we've made in the healthcare delivery system, health disparities are highly prevalent, and there's a lot of evidence to support that notion. If you look across almost every measure of well-being in the United States, there are large health disparities, and they're not going away. Health disparities have been defined by the Institute of Medicine as racial or ethnic differences in the quality of healthcare that aren't due to access-related factors or clinical needs, preferences, or the appropriateness of an intervention. Research shows that racial and ethnic minorities tend to receive lower quality of healthcare even after controlling for factors such as insurance status and income. And this evidence is consistent across a range of illness and healthcare services. The issue of health disparities is something that requires all of our attention. While we've seen significant improvements in health and longevity over the last century in the United States, these benefits have not been uniformly realized by all Americans. Life expectancy has actually improved by more than 4 years for Americans over the last 30 years, since 1980. But for Black Americans, they still live 4 to 6
Hello and welcome to Public Health Live for the third Thursday breakfast broadcast. I'm Benita Zahn and I'll be your moderator today. Before we get started, I'd like to ask that you please fill out your online evaluation at the end of the webcast. Continuing education credits are available after you take our short post-test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best serve your needs. As for today's program, we'll be taking your questions throughout the show by phone. The toll-free number is 800-452-0662, or you may send your written questions by email. Please email us at any time throughout the hour at phlive.ny@gmail.com. Today's program is Collecting the Data, First Steps in Achieving Health Equity. Our guests are Dr. David Zingmund, an Associate Professor in Residence at the David Geffen School of Medicine at UCLA, and Dr. Marsha J. Wilson, the Associate Director, Department of Health Policy, School of Public Health and Health Services at George Washington University, and Dennis Whalen, President of the Healthcare Association of New York State. Thank you all so very much for being with us. Now, according to the Center for Disease Control's Office of Minority Health and Health Equity, minority health determines the health of the nation. Why is this so? The United States has become increasingly diverse in the last century. The 2010 U.S. Census documented approximately 36% of the population belongs to a racial or ethnic minority group. This proportion is expected to grow to over 50% within the next 30 years. And in this context, while health indicators such as life expectancy and infant mortality have improved for most Americans,